I just want to tell you how Martin has got me involved with a group of scientists, which has been really helpful to just chat to people over breakfast or over lunch and get ideas and learn more about B12. So what I'd like to do is just tell you about some of the things I've been up to this past year and what's up for me next year. First of all, I've been listening. When you do research, nowadays it's imperative that you actually listen to patients and the public. That's just part of every grant approval of everything you want to do. So I thought, who could I ask about pernicious anemia? Martin put me in touch with the Gloucester group. Thank you very much. They've been incredibly helpful, giving me stories and telling me about the problems that they've had. And I'd just like to do a straw poll of those of you who have B12 deficiency. You don't need to do this if you don't want to, but I'd like to know which do you feel is the most, that'll wake you up as well, which is the most difficult for you, getting a diagnosis or getting the right treatment. So I'd like to have, or both are equally a problem. So first of all, people who say the diagnosis was a problem but treatment is plain sailing. Could you stand up, please?
Oh, that was it.
That's
very small group.
4 in this group. Okay. Can you sit down, please? And now the people who say diagnosis was plain sailing but treatment is a different story. That's hard. That's 2, 4, 6, 8, 12, 14, 16, 18. About 25, I gather. 26. And now the people who say, well, diagnosis was tough, but getting the right treatment is equally tough.
Everyone else.
That seems, let me just have it. That's more, I think, 30 or more. That's really helpful. Thank you for this very quick involving the patient and public in research. So what have the Gloucester group told me? I'm sure you'll all be familiar with it, that diagnosis is a problem, symptoms are not being recognised and are sometimes so subtle or vague, the doctors don't recognise them. The assumption by some doctors that you have to have anemia, whereas that's not always present. I've heard that before this morning, that doctors aren't aware of risk factors and that doctors aren't aware of all the trouble with testing. And a lot of you said we want doctors to be educated. More on that later. And then with treatment, the main problem seems to be frequency of treatment. And then please do more research. We need more research. So what's been happening? First of all, I want to tell you a little bit about, I've done a talk for GPs in Oxford, and I'll just show you a few slides from that talk. So put your GP hat on, fasten your seatbelts, and off we go. This is, the first slide is to show people how common actually B12 deficiency is. And these are 3 tests. So blue is B12, red is methylmalonic acid that Dominic was talking about, and green is homocysteine. So if you just look at the blue bars, in the younger age group, 21 to 65, it's 5%, 1 in 20 have B12 deficiency. In the 65 to 80-year-old group, it rises to 22%. And in the over 80s, it's 32%. Now, with all the problems with testing, but it may be a bit more, maybe a bit less, but it's a good figure to start with. So then I asked GPs, how many patients do you see in an average surgery? Well, maybe 1, often none. You should be expecting to see at least 1, if not more, 2 or 3 in every surgery that's B12 deficient. If you don't see them, you're overlooking them, because we see more older people, well, unless you see lots of young kids with a flu epidemic, see lots of older people. So we should be seeing this very regularly. And the next thing I've been telling them is symptoms. I won't go through all of them because that's too long. But this is how I remember the symptoms. Mind, so that's memory, concentration, etc. Mood, any psychiatric symptoms, whether it's depression, anxiety, psychosis, I've heard, hallucinations, all sorts of things. Sensory, so that's feeling, so pins and needles, pains, numbness. Motor, that's reflexes, can be either up or down. Muscle weakness, dropping things, especially cups seem to be popular for dropping, bumping into things. Autonomic, so getting dizzy when you stand up. Maybe incontinence, maybe erectile dysfunction. General things like tiredness, they can't sleep because you can't make the sleep hormone, melatonin. No appetite. So that's all the neurological things. And there is more. There's people who have other symptoms, but this is the main ones. And then any fast-dividing tissues need B12, or actually more folate, but B12 helps to recycle it. So that blood, guts, and to some lesser extent skin as well. So blood, anemia, but also other cells, white cells, blood platelets, and then the gut. It's the lining of the gut that can't regenerate as well. and therefore you get problems like diarrhea, weight loss, ulcers in your mouth, sore tongue, etc. And here is a list of the risk factors. I'm sure you know a lot of them. Autoimmune disease, women, age, both the young, because they're now taking nitrous oxide as a party drug, which destroys your B12. And the old, because they don't absorb it as well anymore. And then things like obesity, diabetes, etc. So as GPs, we're having to think B12 much more often, I think, than we do. And this is two pictures. On the left, you see this is the lining of the bowel. See if this works. So this is the lining of the bowel in a patient who's B12 deficient. And you see that these villi, sort of tufts of tissue in the lining, are really sort of short and plump, and these cells are bloated. They're big. They're sort of, where have we seen that before? The anemia with big cells, same process. You can't make new cells, and therefore the ones that you have seem to be more bloated. This is the same patient after treatment. So these tufts of tissue, which you need the surface, and so the longer they are, the bigger the surface, to absorb your foodstuffs. And you see that the cells after treatment have become really nice and small and stacked up like sardines in a tin. And that explains to me why people start not absorbing other foodstuffs such as iron, folic acid, and maybe others, why they might lose weight and why they get diarrhea. I'm sure you can all decipher that quickly for me. This is an article I was sent by a Danish professor, Professor Nexo, because she told me on a conference about a patient, and I emailed her back and say, have you actually written that up? And if you haven't, could you please do so? She said, yes, we have. This is it, but it's in Danish. So that meant I spent an evening with Google Translate and some online dictionaries and a bit of language sense, and then you get that. This was about a patient who started off being treated in Germany with injections they have there, got better so he had pernicious anemia, got better, came back to Denmark, continued his treatment once every 3 months, got pernicious anemia again. And they scratched their heads and thought, what on earth is going wrong? So they checked every little bit of the pathway of vitamin B12 in the blood. They couldn't work it out. It was all normal. And all of a sudden, he started getting better. And they quizzed him And finally, they learned that actually he'd been using his German injections according to the Danish schedule, which is once every 3 months. Once he started using the Danish injections, he was okay. What's the difference? The German ones are dissolved in water, like the injections we have here. The Danish ones are dissolved in oil. So you've automatically got a sort of a depot form of B12. So I think that's really illustrative of some of the problems you guys are having and why we need better slow release preparations. And this is just a slide that I use for the GP of sensitivity means how good is a test at actually picking up a disease. So the Ward et al. Study, that's Dominic Harrington and his colleagues, and at a cutoff of 145 in English money, you pick up 11%, i.e. 9 out of 10 of you are not being picked up on that test if you take that as the cutoff. So the 145, and that's in some labs that's the cutoff. If you increase the cutoff to 199 to 200, you pick up 36%. So 2/3 of you would still not be picked up. If you increase it even further to 244, you pick up just about 2/3. So still 1/3 of you are not being picked up, continue to suffer, have all sorts of awful symptoms and get referred for other things that cost the NHS lots of money when actually we could treat your B12 deficiency. So that's how poor the test is, and that's what I'm trying to tell my colleagues, that this test is not great and you have to know what you're doing with what the result means before you can interpret it and before you can tell the patient, no, you don't have that. So my task for the coming year is to spend lots of times in libraries, or actually online libraries, doing a systematic review of the literature on the different tests, and Dominic mentioned, so that it's total B12, all of the B12 in the blood. Then there's hollow transcobalamin, which is the active fraction that's actually being delivered to cells. And then there's the methylmalonic acid, which is a functional, shows how much B12 is working in the cells. So I want to compare those three, and at the end of the year, by sort of August, I should have a bit more of an idea of what these tests are, so better figures than the last slide. No. So some better figures than this. This is just 2 studies, but I'd love to have more accurate figures, and then we can take these out to GPs and we can take them out to the commissioners, the commissioning bodies, and say, actually, this is what the test is doing or actually not doing. So libraries, and then research. In the end, I would love to do research with patients, but that's a long-term thing if you ever wanted to try. First, I have to get qualified, so I have to do a master's course in clinical research, then you write a proposal, then you find a research group that's willing to support you, you have to get funded, you have to get ethical approval, you have to do the study, you have to get published. That takes 3 or 4 years at least. And then everybody says, well, it's only one study. So you have to do the whole thing over again, because one study means almost nothing in the scientific community. So carry on until retirement. So that's what I've been up to and what I'm doing next year. Here are the picture credits. Didn't take them myself. Any questions?
What I want to say is, there's all this research, which is great, and there's all these new medicines being looked at, which is lovely. But my godson has just passed his qualifications as a GP. He's now doing research at Bristol University. And I said to him, what did you learn about vitamins? He said, in the 6 or so years, we did 3 weeks. I said, what did you learn about vitamin B12? He said, I was told it wasn't important. It wasn't an important vitamin. And I just wondered, we could get all this together, but is there anybody here who has any contacts that can get hold of the teaching profession and say, could you teach them a bit more, please?
Well,
and it's not really a question, I'm sorry, I just didn't know when to ask that.
That's a really good comment, and that's what I'm trying to do with my talk for GPs. And I've been asked to do it in a couple of other places. So it's slow. It's going to be slow. It's going to take years. They reckon between knowing that aspirin actually worked as prevention for people who've had a heart attack and it being prescribed in people who've had a heart attack took at least 10 years. So it's not going to happen tomorrow, but if we keep hammering away at it, keep trying to get the evidence out to the profession, then hopefully at some point the penny will drop.
Thank you. You talked about talking to your colleague GPs. I don't remember, unless I was having a micro-sleep, whether you told us what their response was to your presentation, and have they taken on board the things you've been suggesting to them?
Very interesting. Of course, you don't hear the comments, all of them, but the comments that I did hear were that was the most useful talk we've had for years. And so that's all I know.
You mentioned the depot form of B12. What is that?
It's basically that in Denmark they use just the same dose, 1 milligram of B12, same dose as we use here, but it's dissolved or suspended in oil. And we know a lot of other medications that we want in a depot, we suspend in oil. You know, the depot contraceptive, depot psychiatric drugs, they all get suspended in oil as far as I know.
So does depot have a meaning?
Well, the meaning is you deposit it in the muscle and from there it slowly seeps out into the tissues. Whereas the water-based just gets absorbed much more quickly. And what you want, as Anna was saying, you want a steady stream. Or as my mother will say, you can't eat for 3 months in one go either. So you want a daily, and I want to say again, I think people are struggling, but you can use oral tablets because 1% of an oral dose somehow trickles through the bowel. So you need much higher dose than you get in your food. We need about 5 micrograms a day. So if you take several milligrams, a lot more, 100 times, 200 times more, you should be okay. And I know people who've topped up their injections with oral tablets or with sublinguals, whatever it is, and feel a lot better for it. I think we shouldn't stop until your symptoms are gone all of the time. They shouldn't just be gone for the first 2 weeks after an injection. You should be constantly symptom-free. That's the aim of treatment, like it is, you know, with asthma, with diabetes. We aim for people to have a normal lifestyle, not to be up a few weeks and then down a few weeks and then maybe up again. That's what we need to aim for. Yeah.
Can I make an appointment to come and see you? Failing that, can we have that as something we can take to our own GP?
Unfortunately, I don't have my own practice. I work weekends.
That's fine.
However, Martin and Beta have just agreed that we should do a blog. So that's what I'm aiming to do, to put a lot of this information onto a blog, including that sort of figures and things, so that in a form that most of you could access and read, but also that the profession could look at if they wanted to.
That message gets to GPs with regard to taking tablet form, and so they stop giving the injections. Is that a worry and a concern? Because we could go backwards with uninformed GPs suddenly getting we should take oral tablets, when what I think most of us that have read Martin's book are getting, we shouldn't be, taking sublingual and the sprays is one thing, but taking the tablets is, am I making myself clear? I'm not.
Yeah, so there's two ways you can absorb your B12. One is the intrinsic factor route, which is highly efficient for tiny amounts of B12 in your blood. And the other is the sort of, it seeps through the wall, the bowel wall, whether it likes it or not. So if you only get really tiny amounts in your food, intrinsic factor is the way to go. If you lose that, you rely on that tiny amount, about 1% of an of a dose that you take in tablets. So as long as the dose is high enough, at least in theory, as Anna was saying, there's no evidence in practice because nobody's doing that, but at least in theory, that should be, I'd love to do a study, but that's another 10 years. At least in theory, should have enough, as long as the dose is high enough. And we think 1 or 2 milligrams, maybe it needs to be 5, we don't know. GPs obviously are worried if they have to start giving injections to 30% of their older people, that's going to bankrupt GP surgeries that already are struggling because the government has reduced the money. So somehow we need to find other ways, like self-injecting, like tablets, sublinguals, whatever it is, or the once a year variant. We need to find other ways because it's a huge public health problem. 5% of young people are struggling, and only 1 or 2% at best are picked up from those. So there's 3% of younger people, and about 20% of our over 80s are not diagnosed and not treated.